Hello, my name is Angela Stubbs, and this is Micah Anderson and Caitlin Casey, and we're going to be presenting today on the non-motor symptoms of Parkinson's disease. So by the end of this presentation, we hope for you all to be able to differentiate between the various non-motor symptoms and their treatments. Parkinson's disease is a progressive disease, but the underlying mechanism is due to the development of Lewy bodies, which are basically protein aggregates in the substantia nigra or movement center of the brain. And so because of these protein aggregates, the patients can start to have bradykinesia or slowed movement, rigidity, a pin-rolling resting tremor, and postural instability. These are our main motor symptoms that we are typically most familiar with. As the disease progresses, they can present with non-motor symptoms due to those Lewy bodies moving into other parts of the brain. And so we will discuss those today. One of those non-motor symptoms is going to be the dysphagia, which is difficulty swallowing, and then siluria, which is drooling. So our treatment options for these are going to be the glycopyrrolate, atropine, and botulinum toxin. But the guideline recommendations actually recommend first line as non-pharmacological due to the side effects of these medications. So first line, they recommend speech and language therapy, and then if the patients fail on those, they will transition to medications. The botulinum toxin actually has the most data to support its efficacy in treating siluria. However, because of its cost and patients needing to go to an office visit or needing to be seen in office, we will not really see this being used. Our main medications will be glycopyrrolate and atropine. Both of these medications are anticholinergic and can cause dry mouth, urinary retention, constipation, and blurred vision. But there is note that these do not cross into the blood-brain barrier, and so there is little risk for falls and for cognitive effects. Glycopyrrolate is also known as Qposa, and it's going to be given 3 times a day. It does come as tablets or liquids, and the liquid must be scheduled around meal times. It should be given either an hour before or 2 hours after. The atropine is going to be a 1% sublingual solution, and you'll be placing 1 to 2 drops on the tongue every couple of hours.
So there are 3 primary sleep disorders that affect patients with Parkinson's disease. These are daytime sleepiness, nighttime wearing off, and rapid eye movement sleep behavior disorder, also known as RBD. For the treatment of daytime sleepiness, first consider discontinuing dopamine agonists that the patient may be taking or consider initiating modafinil. Nighttime wearing off can make it difficult for patients to sleep or make it difficult to stay asleep. Consider bedtime dose of carbidopa-levodopa, adjunct entacapone, or a dopamine agonist. Normally during REM sleep, we are paralyzed and don't make any movements, but with REM sleep behavior disorder, people physically act out their dreams by having sudden arm and leg movements or shouting during sleep. For this disorder, decrease anti-Parkinson drugs at nighttime, and you may consider clonazepam or melatonin to aid in sleep. Moving on to one of the most common non-motor symptoms, which is constipation. Constipation is defined as less than 3 bowel movements per week. Non-pharmacologic treatment may be helpful, such as increasing fluid and fiber intake, as well as increasing physical activity if the person is able to. Fruits, vegetables, whole grains, and nuts and seeds are foods that contain fiber. If the patient is on any anticholinergic drugs, consider discontinuing, since these can significantly contribute to constipation. If treatment is needed, then initiate a bowel regimen if the patient is not already on one. As Parkinson's disease progresses, individuals often develop dementia. Therefore, dementia can contribute to the incidence of these psychiatric symptoms. But medications such as carbidopa-levodopa can also cause things like psychosis, hallucinations, or delirium. It is usually dose-related and can be reversed with a decrease in dose. Atypical antipsychotics such as quetiapine or clozapine may be used to treat psychosis. The newest second-generation antipsychotic, Nuplazid, is specifically indicated for the treatment of Parkinson's disease psychosis. It can be administered without regard to food and the capsule contents may be emptied onto 1 tablespoon of applesauce, yogurt, pudding, or liquid nutrition supplement. It should be administered immediately. If this is done, it should not be stored for later use. An ECG should be done periodically since this medication can cause QT prolongation. You should monitor for changes in mental status, for nausea, constipation, and lower extremity swelling. This medication does increase risk of falls due to somnolence and orthostatic hypotension.
All right, the next non-motor symptom is cognitive impairment, and this could be either dementia or non-dementia related. Patients are generally going to see memory issues, decreased ability to retain information, focus, pay attention. All these can progress to affect ADLs, or activities of daily living. We're going to see two main treatments for this cognitive impairment. The first is donepezil. The main thing I want you to know about this drug is the administration. So the patient needs to take by mouth once daily at bedtime. It's at bedtime so that the patient can sleep through the side effects. Some side effects like low heart rate, fainting, dizziness, and drowsiness. And some other side effects I want you to be aware of are things like nausea and vomiting, and maybe a headache. The other treatment is rivastigmine, and it's important to take by mouth twice daily, and then to monitor for dizziness, headache, nausea, and it also has a fall risk. So both of these drugs can potentially cause falls. Next one is orthostatic hypotension, which is defined as a systolic blood pressure decrease of at least 20 millimeters of mercury or a diastolic decrease of at least 10 within 3 minutes of standing. And this is important because the patient stands up, might black out, might get dizzy, might faint and fall over. So it could be potentially very serious. For treatment, first we want to check all of the pharmacological causes. We want to see the patient's blood pressure medications. See if we can change the dose, maybe even change the drug. And then we may consider adding a drug like midodrine. And also I want you to pay attention to the administration of this drug. So take 3 times daily by mouth. And it's important to not take after evening meal or less than 4 hours before bedtime. And it's important to do that so that we don't have as much supine hypertension. Or sometimes when the patients lay down, they can get these high blood pressure symptoms such as blurry vision, a really bad headache, these pounding in their ears. I also want to monitor for itching, shivering, and this skin tingling. Then finally, our last non-motor symptom is urinary dysfunction. You can see urinary frequency, urgency, and incontinence. The main treatment we see is solifenacin, and mainly because it has the most data in Parkinson's disease patients. You want to take it by mouth once daily. It's going to have a lot of these drying side effects. Things like constipation and dry mouth. But also be aware of a headache, confusion, and potential angioedema.
So in conclusion, here is just a wrap up of the non-motor symptoms you may see with Parkinson's disease and their treatments. For dysphagia and sialorrhea, we have glycopyrrolate and atropine. For sleep disturbances, we can use modafinil. In constipation, there are a variety of agents that may be used. For psychiatric disturbances, there's pimavanserin. In cognitive impairment, we have donepezil and rivastigmine. For orthostatic hypotension, there's midodrine. In urinary dysfunction, we have solifenacin. These are our references we used, and we thank you for listening to our presentation today of non-motor symptoms in Parkinson's disease.